welcome to the Sweaty Pillow podcast. I'm so excited about our guest today because we've never had this type of doctor on the podcast. So I'm so intrigued to have this conversation with Dr. Rebbecca Hertel. I'm going to introduce your background because it's really impressive. You're a board certified osteopathic family medicine physician, a certified menopause practitioner, and an expert in menopause and sexual health. Where have you been my entire life, Dr. Hertel? I'm so excited to have this conversation. Welcome to the Sweaty Pillow.
Thank you so much for having me. This is just absolutely wonderful.
Well, we've got an exciting little journey for us to talk about today. But first, before we kind of get into how you help so many women, tell us about your journey in menopause. What's your why? Why did you start all this?
Yeah, so, I've been taking care of human beings from birth to end of life for almost 20 years now. And like so many of us in this space, I was never taught about menopause at all. So my journey occurred, I think, like so many others in this menopause space, it was when I started to go through perimenopause. And it was a little muddied because I had my last baby right before I turned 40. And so I think some of those perimenopausal symptoms were occurring, but I just didn't realize it because I had a baby and, I was waiting for all of these things to settle down. But after I stopped nursing him, I was just not starting with these hot flashes and night sweats and not being able to sleep. But most importantly, I was at work and I couldn't remember what I was doing. I was reading through charts and I was reading through them 2, 3, 4, 5 times. And I thought, I'm losing my mind. Something is happening to me. And no one knew how to help. I can't even tell you how much money. And I'm a physician and I didn't know where to go. Menopause was not even on my radar. I was still getting periods. It was not even a thought of my mind. And I started going down a rabbit hole of just research and research and research. And I literally thought I had adult onset ADD and was talking with my partner about like, do I need to go on Wellbutrin? Should I try some Vyvanse to see if I can function? And I came across just that rabbit hole and Mary Claire Haver and Dr. Heather Hirsch and took courses and educated myself and took every course that I could, everyone that I could pay for and buy and learn, I took. And so became a part of the International Society for Women's Sexual Health, the Menopause Society, and it just exploded. And I wondered where this education was my entire career, and it legitimately changed the trajectory of my career. And so, and here I am.
It's crazy. And we've had so many doctors on the podcast, and I didn't know what I didn't know before we started researching and having experts on the podcast. But what's alarming to me in particular is you're a doctor, you're a physician, and these things are happening to you. And it's not automatic. Like, think back to when we're teenagers, we're expecting, we're 11, we're 12, our mothers are, school, whatever said, you're going to get a period. You know exactly what's going to happen. But we're in our mid 40s, we're early 40s, symptoms are happening. We don't even put 2 and 2 together until doctors say, maybe you should go on antidepressants. Maybe you should go to do more yoga. And it's a messy bit of business, but doctors don't even know what's happening to you.
No. And it's interesting because I had this conversation. I have a 13-year-old daughter too. And we were talking about puberty and she was really moody. And I said to her, I said, how you're feeling right now, one day, this is how you're going to feel through perimenopause. It's just like your puberty, but it's going to be then. And she's like, Mommy, I don't need to worry about that. That's a really long time and really far away. And I said, I know, but when it does happen, you're going to know exactly why. And because we were never taught that. I was never taught about, definitely not perimenopause, definitely not. I knew that my periods were going to end one day. That's it. And medical education didn't teach us how to treat the midlife, perimenopausal, menopausal women. And definitely nothing about sexual health at all in that space of life either. So.
Oh, hell no. That's so true.
We just didn't
our mothers, No, exactly. Our mothers didn't talk about it. It's gross to talk about. And when I start
That's right.
asking even my mom about it, it's kind of, she's got the discomfort. Like that generation whose parents
Yes.
were in the depression and suffered through stuff, it's like, oh, suck it up, kids. You're fine. You're
Yes.
going to get through everything. But our
Yes.
daughter's generation will be way more prepared. There'll be
That's
way
right.
more education with family medicine, God willing, by then, by the time our daughters are through it.
Yes,
But
yes, and
we're
it has
stuck.
to be. It has to be. I kind of put that challenge out there not that long ago to say, all of us providers that deal with, pubescent children, pubescent, 12, 13, 14, and your young adults, we need to start talking about that. When we're educating them about puberty
Mhm.
and pregnancy, perimenopause and menopause has to be that next conversation right along with it,
Yeah.
because they don't know, and they need to understand that it's okay and that we're really, really cool women in this stage of our life. We have so many things to offer, and it's not scary. We're not old. We're not,
Yes, that's so true. So if you don't mind sharing, because I've been really open about my personal journey and what ended up helping me. So you have a baby right
Yes,
before you're 40.
yes,
These things are start happening. Can you,
yes.
educate our community on what you took all these courses? What did you do for yourself to get you
Yes.
the support you needed?
So, like so many, I did find someone, telemedicine, unfortunately. So it was good and bad. So I was told that you just can't multitask anymore, because I was saying I can't multitask. I'm a mom of six. I have a full-time job. I all of a sudden I can't. And she's like, well, honey, you're just going to have to do one thing at a time. And I thought, well, that is not conducive to my life. And I could do it like 2 years ago. And so,
Yeah.
but I did get some progesterone. So I was thankful for that. I could start sleeping because I was starting to have horrific night sweats. I mean, like I call them super soakers. You're getting up, you're sticky, my body's smelling funny. I don't even want my husband around me because I'm like, what is this smell? And so I started on that. And at some point, it just wasn't enough. It did help me sleep, but the vasomotor symptoms, those hot flashes, those night sweats, the decrease in libido, all of those things started, and I actually had to find somebody else. So
Mm.
I'm searching, I'm getting educated at the same time, and I'm like, I think I need estrogen. And so, but finding someone who was as educated to do it for me and who knew how to do it in perimenopause was a little bit of a challenge. And so I did find someone, and through my education and hers, we kind of came together, and I started on an estradiol patch. And that was a game changer. So it,
Mhm.
it really, really helped control the hot flashes, the night sweats. I remember driving to work, and because I used to feel like a fog, like if you're looking through dirty glasses, that's how I would explain it to my patients. In addition to just intrusive thoughts of like driving off the side of the road, and thinking,
Wow.
this doesn't make any sense. So I'm driving to work, and I was probably on an estradiol patch for maybe like 3 weeks or so. And it was like the fog lifted. Everything
Mm.
lifted. Everything was like these clear blue skies. And I thought, holy cow, what is happening? And I slowly was able to regain my life back, my career back, that umph, like just, that bad woman that in
Mhm,
the,
mhm,
conference room. And and that enabled me to just really regather the structure of my life and
mhm,
regain it back and be control of it instead of it controlling me and these symptoms controlling me. And it just helps so much now, even just with my patients now, but saying, I get that. I remember that. I can help you through that. And so, as you know, in perimenopause, you're changing dosages. So I've gone up, I've gone down, I've changed different routes, because now I'm in late. So I actually went 290 days and thought, oh, yeah, this is it. I'm 47 years old. This is going to be great. And sure enough, then I get a period, and I thought, oh, I'm going to start all over again. So, um, and with perimenopause, you do have to change those things because you are still fluctuating. Those ovaries are still, the estrogen is still fluctuating, and I have definitely found that too. That you need to be verbal with your provider and say, okay, I need to switch this. I want to try this instead. I think I need to go up. I think I
Mhm.
need to go down. And so I do that and added testosterone at one point to my regimen, which for me, and I'm lucky, about 50% of women, it doesn't necessarily help as much. For me, it definitely helped with the libido, with some of that brain fog.
Mm,
So,
mm. Interesting. I have a kind of crazy question for you to
yeah,
consider. So I'm going to say an age just for the sake of argument, because everyone will experience different symptoms or their timing could be different, but call it 48 years old for argument's sake.
yeah,
Why couldn't there be almost a standard protocol? You haven't had your period for a year, your X age, you've got all these symptoms. That is the age that you need to start progesterone, an estrogen patch, and testosterone. Doesn't that kind of, and I'm oversimplifying it to make a point, but wouldn't that help
sure. So,
so
so
many
in a,
women?
right. So at 48, if they've gone a year without their period, so
Mhm.
they're already, so they're menopausal. Yeah, I think, because it can happen there's so many different levels to it. I guess, that whole word that it's nuanced. Um,
Right.
for some women, if they don't have a uterus, obviously, if we're generalizing, they had a uterus, they stopped their periods within a year. You're right, it could help. I do one hormone at a time because for some women,
Mm,
they don't need the testosterone. They're doing really
okay.
great off of it. And maybe 5 years later, they might need that. Maybe they're not
Mm,
experiencing any of those low testosterone symptoms. So, what I have found doing what I do is I always say every woman's a little unicorn. Like they are
mm.
just different and the same in different ways, if that makes
That
sense,
totally makes
right?
sense. Yeah. Yeah.
Yeah, what one woman needs, my next patient does not. And so,
Mm,
which for me makes it really fun. That's why I love
mhm,
that because you
mhm.
are just, it gives you that ability to take every single story and journey and you tailor their um their regimen to that.
Mhm,
And
mhm.
so if they have a uterus, and they start estrogen, they obviously are going to need progesterone. Some women I can give them progesterone and they don't need estrogen right away.
Okay.
So, and then eventually they typically do. Um, but that's probably why we don't generalize because every woman's regimen is so nuanced and so different
Right.
that we
That makes
don't.
sense.
Yeah, if that makes sense. Yeah.
Yeah, it totally does. It has to be custom. And that's why I was
Yes.
kind of, I steered the conversation that way so that we could come back to your work
Yes.
and the importance of experts that see a woman individually and her needs and her risk factors. That's why what you're doing is so important. And that's
Yes.
why this new kind of era of virtual health and the
Yes.
fact that you do the testing and you have one-on-one consultations is so valuable and the best money that we could spend on the investment
Yes.
of our health, our healthy lifestyle, our risk factors as we age. So tell us about your practice and what you do and how you help women.
Yes. So I'm in telemed practice. I am a small business owner, osteopathic midlife health. Right now, I'm affiliate with the Heather Hirsch Collaborative, and that's how I started. And it'll almost be a year on just the telehealth side. And so, what's really wonderful about that is they're an hour-long visit.
Mhm.
And you cannot, my whole entire medical career was 15-minute visits. And
Mm,
you cannot give appropriate care in 15 minutes. You just can't do it. They're really, they're hardly getting the introduction out in 15 minutes, right?
yeah.
So then to be able to tell their entire story and you're educating all of the education that's needed surrounding that because so many women come to you not knowing anything. They don't even know what they need and they don't know what they don't know.
Mhm.
And so we spend that time, a lot of education, talking about the WHI or undoing some of those, the myths that they have. And then if you can piece through then the sexual health side of that as well, it's women for the most part were raised not to discuss that. So to pull that out and then to, have them be comfortable with you, that hour is so crucial because they've already given so much to you and then you can piece out some of the more intimate details and experiences. And so, and that's that first initial hour. And then we come up with a plan and we do it together. So it's 100% shared decision making. I do not make the decisions. I give you all of these lovely tools and we pick from them together. And, my perimenopausal patients, some of them just want the conversation and they don't leave with
Mm,
anything but a journal.
right.
And they come
Okay.
back to me later, they journal everything and they're
Mm,
like, I'm okay. I just needed to know what was happening to me and I needed someone to
mm,
validate my experiences.
mhm,
And
mhm,
so just that's been crucial. And so then I do half hour visits and follow-ups after that. And for, however long they need. I typically like to see patients back in about 8 weeks or so, but if they're doing great, we push it out. If they need me more and they actually need to see me, then they book a visit. And it really is led by whatever they need to support them and to get them feeling, I always say, at least 70 to 80% improved. If it's better than that, that's fantastic.
mhm.
Sometimes perimenopause can be a little bit more difficult because I think part of that education is I'm not shutting down your ovaries. If we choose menopausal hormone treatment, I'm not shutting those ovaries down. So I'm giving you, I like to say, a mattress pad, right? So when you fall or that estrogen falls, you're not falling on a hard floor. You got a little mattress to
Mm,
support you.
love that.
Yes. And so once they understand that, I can shut your ovaries down with different types of medicine, but not menopausal hormone therapy. That's just going to
Mm,
be, that cushion. And then once those ovaries peace out, it's so much easier. They
yeah.
say goodbye. It's so much easier to treat because we know we're not fighting with your ovaries giving the high estrogen, low estrogen. It's just going to be
Mhm.
that kind of that flat line, and then we can dose appropriately. And sometimes they go up, sometimes they go down on their dosing. But most of my women are like, "Can I just hit menopause already?" And I'm like, "I know, it would be so much
Yeah.
easier, wouldn't it?"
It's clearer. Um,
Yeah.
but in your protocol, you do, if a woman after the conversation, you guys agree that no, there's something off, um,
Mhm.
12 months have passed since your last period, you
Yeah.
do a requisition for lab work and to see a hormone panel.
Yeah, so how we have the conversation about hormones is I always tell them I don't need hormones necessarily to treat you. If they've gone 12 months and 1 day, they're officially in menopause. I know that. I know your estrogen is low, especially if you're having symptoms.
Mm,
I know your progesterone is low because that actually starts to decline first. The main one I like to test for if we're going to decide on testosterone at some point is a testosterone and a sex hormone binding globulin. But I give them the option. I'm like, I don't need it. I can do it, absolutely, because some women, for them,
mm,
it's validating. Like, I
yeah.
want to see the numbers. I want the data. And every clinician is a little bit different. So I
Mhm.
always give them the option and I tell them the reasons for it or not. And so some women choose to and some women don't. Again, unless we're going to do testosterone. So if they're mainly having, I call them like dry symptoms, right? So dry skin, vaginal dryness, hot flashes, night sweats, genital urinary syndrome of menopause, then those are more low estrogen state. Brain fog, joint pain, that's low estrogen. If they primarily have low estrogen, I'm going to start the estrogen first, the estradiol
Mhm.
first, and we'll decide, given their risk factors, on the route. So a pill, a gel, a spray, a patch. Then if they have a uterus, we know we have to add progesterone at some point. Usually I tell them about 3 or 4 weeks, I'm going to add progesterone to you. Um, and I like a low and slow approach. So we start at the lowest dose so we don't overshoot because women will feel absolutely terrible if you start an estrogen dose that's too high.
Okay.
So just as terrible as if it's too low. So you get like the breast
Interesting.
tenderness. Yes. Calm
Oh,
before.
okay.
Yep. Your mood gets terrible, ragey, breast tenderness, bleeding, bloating as well if that estrogen is too high. And so I've had a lot of
Mm,
women come to me because they were started on a high dose. And I'm like, I think we just have to take that off. Let's take it off. Let's start
okay.
over. And then usually the last thing I'll start is testosterone, depending, on their symptoms that are
Mhm.
occurring still. And that's just how I do it. In perimenopause, sometimes it's a little bit different. It depends on what's going on, and it depends on if they're early versus late and what their symptoms are. So that's,
Mhm.
the conversation's a little bit different. But in a menopausal person, um, if it's more anxiety and they're not sleeping, then I might start their progesterone first, and it usually works a little bit quicker too. And then 2 to 4 weeks, we're going to start the estrogen if they need it.
All right. You have this, you exude this energy of comfort. And I think women would gravitate to your very personal approach. Your bedside manner is not like a normal doctor in general, but you do have this combination of great insight, education, intelligence, experience, but comfort. You're giving me comfort now. And I want to
Thank
expose
you.
you to our entire
Thank you.
community. I know. I
Thank you.
saw that
I love
there's,
that so much.
yeah. It's important, right? Because it is a scary time and we're frustrated. We're not
Yes.
getting heard.
And women
Um,
are, they're vulnerable during this. They're crying. I'm crying. They're crying. Or it just, they're really opening their heart and soul to you about things that they have not talked to anyone else about and have been
right.
scared to talk to other people about. And so it's such an important position to just listen and let them just pour whatever it is that they
Mm.
want to pour to you.
Yeah, it's really valuable. We've got, we do a lot of, we put a lot of questions out to our community on the type of education that they're looking
Yeah.
for. And a common question or a common concern is they don't feel heard. They go to their family doctor who they've trusted for 30 years, who's kind of blowing them off. And it's getting us pretty angry over here at the Sweaty Pillow that women are not getting heard. It's kind of demeaning, and they're like, well, what the hell do we do? And
Right.
so it just kind of came to us in the last week that we are going to publish on our website a list of virtual healthcare providers, because we're in that
That's awesome.
age where you can get more than just learning from TikTok and Instagram. There are, you know, educated professional doctors out there that are trained
Yes.
to virtually support you. I
Absolutely.
saw the list of states, and can you
Yes.
remind our audience the list of states that you are licensed to
Currently
practice
licensed.
virtual?
Yes.
Yeah.
Yes. Yes. So New York, I'm going to try to remember them all. New York, Pennsylvania, Ohio, Illinois is new, New Jersey, and Florida, California. Did I get them all? Vermont. I think I got them all. I might be missing one.
We'll publish it on our site,
So,
or when we do the podcast, because we
and
want women to find you.
yes, and I'm not far from Canada. So
Okay.
I'm actually about probably an hour and a half from Niagara Falls. And
Okay.
so, yeah, at least on this side. And
Right.
so I know a lot of women, if they can get to, you know, they'll come they'll drive over the border and they'll have their visit. And so those are always options too for patients. And
Okay.
so that's the nice thing about telehealth too.
Yeah.
As long as you're in
I love that option.
the state that we're licensed in to see you.
Okay, that's awesome. Tell us about the symptoms that women are complaining about the most. I always like to get an update on what you're hearing, because that kind of
Yeah.
triggers our community to go, wait a second, I've got 4 out of 5
Yeah.
of those. I need to be seen. Yeah.
Yes, I would say, the top symptoms I typically see are your hot flashes, your night sweats, your brain fog, mood,
Mm.
and libido. So those are the
Oh,
big ones.
so we can't just blame that on our husbands, because some people would be like,
No.
okay, I'm
Yes.
having a bad run in my marriage, but it's way
Well,
bigger than that.
yes, and I'll tell you, there is a big percentage of women that get divorced during this time because of all of
Oh.
these changes that are occurring. Their partners are like, I have no idea what's going on. These women are like, I have no idea what's going on. I must not love my spouse anymore. And
Mm.
then there's a dissolution, a dissolvement of these relationships. And so, just as much as of an importance to educate women on what's going on, I think is to educate the partners that what's going on as
Yeah.
well, and they come together. And so, that's what I loved about the M Factor. And I'm actually going to Chicago next week for one of the screenings. And there was something to be said, like, I hope that these women bring their partners with them, and watch it
Right. Yeah.
together. It's so
Yeah.
important. So
Yeah.
important.
It's very true because that's usually the closest to home is your intimate partner. And if they think you've just gone off the deep end, that's just going to
Yes.
gaslight the whole
Oh
situation.
gosh, they do,
Yeah.
and then there's turmoil and fighting. And what we're not stopping to realize is these women, most of the women that come to me, they are like, I love my partner. I
Mhm.
just don't want to have sex anymore with them. I don't
Oh,
think about it. I want to be intimate. I don't think about having it. I really just don't want it. I don't want anyone touching my body. A lot of women don't even want
mm,
their own children hugging them because they get these sensations of just skin
mm,
irritability,
mhm.
and so, but if you think about night sweats and hot flashes, you're not sleeping. You don't
Yeah.
feel good. Your joints hurt. Insomnia, you're not sleeping. Your cortisol's up, your stress is up. In addition to navigating children and routines and jobs and maybe parents, taking care of your own parents, all of these things, that's what happens to then their desire, right? Their desire is just like over here. They're not thinking about it. And when you don't feel good, women notoriously don't want to be intimate if they're not feeling well, or they just don't have that energy left in them at night when they're going to bed. And then there's,
Yeah.
partners rolling over, and, you know, you're going to bed in like your full bodysuit, hoping that like he's not like, oh,
Don't
it's fine
touch me.
tonight. I do it all the time.
Yeah.
My husband gives me the look, and I'm like, "Don't even think about it. It's past 9 p.m."
Catch me at 8:45.
You got it. You got it. I'm like trying to put the 7-year-old to bed. I'm going over work stuff, and I just thought, you finally get into bed for like 2 minutes, and like they're like, they're looking at you, and you're like, no,
Hell no.
hell no. But put it on the calendar. We're so I'm like, I put
Yeah.
everything, and I think that's one thing with like desire and intimacy too, that like we do put everything on the calendar. And
Yeah.
that should be one thing we put on the calendar. Let's set a date night, or maybe it's
Mm,
every Friday, or maybe, because when we get into these routines, then it's not spontaneous. And when you've been with someone for quite some time, what is it, after 18 months, the honeymoon period, it's not as spontaneous. It's not like in Hollywood. And so
yeah,
you do
that's true.
have to make that time to be intimate. And it doesn't have to mean, that intercourse is going to occur. It could be holding hands and watching a movie together, and just like, giving a massage or whatever that may be, so that you're having some intimacy together.
It's really important. I think we need to
Hmm.
book a whole other podcast with you specifically on that topic
Yes,
because
yes.
let's save some marriages. Let's educate the
Yes.
men. Let's
Yes.
talk about sex.
Yes.
That would be a lot of
Because
fun. Yeah.
yes, right? Because the men are wanting to get Viagra, but if the women aren't reciprocating with that, I'm not sure what you're gonna do with all that. Yeah. No.
Keep
So
that thing away.
you just wasted your pill, honey.
Right? Jesus. Grab your laptop and go to another room.
That's right, exactly. Go
Oh my
outside, it's
gosh.
cold out now.
I love this. Okay, so the last question I want to hit you
Yeah.
with is what are the 5 things that you can recommend women that know something's up? They know that they're dealing with perimenopause at least. What are the 5 things that you recommend they do right away?
So definitely one is to understand that this is what it is and it's okay. This is part of life.
Mhm,
The other one is to find yourself a very skilled menopause clinician if you are suffering. So if something is going on and you are just like, I am not okay with this, I don't feel okay, you need to find
mhm,
someone who is educated in midlife and menopause. Being a family medicine physician for so long, I every day felt so awful for the women I know that I blew off because I wasn't educated. So you really
mhm,
have to find an educated provider. Then all of the other things, you need to prioritize your health. That is important. You have to make the time for yourself. So whether it be getting your appointment booked, you need to prioritize your sleep. You need to make sure that you're eating healthy. You need to make sure that you are resistance training and getting that exercise in. It's more important now than it has ever been to make sure that you're staying strong, that you're eating clean, that you're prioritizing your sleep. So because all of that is your health.
Mm-hmm.
And
Those are the pillars. Yeah.
those are it, and I would argue to say that it starts in our young women, right? So I have women,
Mm-hmm.
my daughters are in their 20s. We talk about it now. So that way they're not catching up once they're 30
Mm-hmm.
and 40. And they've already had this really amazing foundation of clean eating and drinking enough water and getting enough sleep and knowing that it's okay to be selfish, to prioritize your health, because you are no good to anyone else if you don't.
Yeah. Yeah.
So
So good. Those are great. Great formula. Let's get after
thank
it.
you. Yes,
Thank you,
yes,
Dr. Hertel.
absolutely. Thank
You
you
laid it out, and we
so
had some
much.
laughs. So
I
much
know.
fun.
That's always so much fun. I appreciate you having me on here. This was just a wonderful conversation.
We'll have you back. We got to get into the sex.
Absolutely. Yes, yes. Let's do that. I would love it.
Amazing. Thank you.